Often, when thinking of the body's gas exchange, the focus is primarily on oxygen. This includes the inspiration, exchange, and delivery of oxygen. However, just as important as oxygen delivery is the exchange of this gas and removal of carbon dioxide from the body. So, today we will focus on the movement of carbon dioxide in the body as well as exploring the Haldane effect. Upon inhalation, air moves through the nasal cavity, oral cavity, or both to enter the body. Next, this air travels down through the pharynx, larynx, and trachea respectively. At this point, the trachea divides to supply each of the lungs. When these branches enter the lungs, they are referred to as the right and left bronchi, located in the right and left lung respectively. Next, in each lung, these bronchi branch off, eventually resulting in many smaller bronchioles, which terminate into tiny sacs known as alveoli. The divisions of the bronchi, as depicted in this illustration, are classified based on their branching. The first branch from the trachea are the primary bronchi, which further divide into the secondary and tertiary bronchi as shown. Then, the bronchi divide into many much smaller structures known as bronchioles. The bronchioles terminate into alveoli, which are tiny grape-like structures blown up in the smaller image. These alveoli serve as the site of gas exchange for both oxygen and carbon dioxide. In this enlarged and greatly simplified alveoli illustration, one capillary is shown to detail gas exchange. Air within the alveoli passes oxygen to the capillary blood, while carbon dioxide from the capillary blood is supplied to the alveoli by diffusion. The oxygenated blood is now pumped back to the heart, represented by the red, to be transported to the rest of the body. The continuous supply of deoxygenated or carbon dioxide-rich blood, represented in blue, is pumped to the alveoli through the lungs from the heart. Like the capillaries and the alveoli, the tissues of the body possess capillary networks as well. These capillary networks carry the oxygen necessary for the many tissues of the body to function. Again, by simple diffusion, oxygen can move into the tissues. This oxygen is then used by the tissue cells in their metabolic processes. During the metabolic process that uses oxygen within the tissue cells, carbon dioxide is produced. By diffusion, this carbon dioxide travels into the same capillaries that delivered the oxygen to the tissue cells. These capillaries lead to veins that will eventually carry the byproduct back to the lungs for expulsion from the body. Both oxygen and carbon dioxide are carried through the blood in different ways. First, oxygen may be present within red blood cells or dissolved in the plasma. Most of the oxygen is bound to hemoglobin within the red blood cells, while very little is dissolved within the plasma. Oxygen does not dissolve readily due to its poor solubility. On the other hand, carbon dioxide is present within the red blood cells bound to hemoglobin, within the plasma dissolved, or in both locations as bicarbonate. Even though it is more soluble than oxygen, still only a small percentage of carbon dioxide is dissolved within the plasma. A slightly larger percentage of carbon dioxide is carried bound to hemoglobin. When hemoglobin bound to oxygen loses its oxygen component, it becomes far more likely to pick up carbon dioxide. The largest portion of carbon dioxide in the blood is transported in the form of bicarbonate. The reaction required to form bicarbonate is much slower within the plasma than in the red blood cell. This is because the carbonic anhydrase enzyme within the red blood cell speeds up the bicarbonate forming reaction. Bicarbonate is released from the red blood cells into the plasma through a carrier protein in exchange for chloride entering the cell, known as the chloride shift. The Haldane effect, and consequently the Bohr effect, are directly related to hemoglobin activity. When hydrogen generated by the carbon dioxide reactions and carbon dioxide levels increase, hemoglobin begins to release its bound oxygen. This process is known as the Bohr effect and breaks the oxyhemoglobin molecule. In direct consequence, the increased oxygen release from the hemoglobin causes an increase in the hemoglobin uptake of hydrogen and carbon dioxide. This process is known as the Haldane effect and creates carbaminohemoglobin molecules. The function of these two effects together account for the extreme efficiency of gas exchange. The hemoglobin that gives up the oxygen to supply the tissues already must travel back to the lungs to get more oxygen. So, it picks up and carries the byproduct carbon dioxide on the way for expulsion from the body. The precise balance and exchange of gases in the lungs and tissues is imperative for normal body function. In fact, disruption of the balance between these molecules can result in difficulty breathing, loss of organ function, and ultimately death. Next, we will discuss a study that explored the imbalance that patients may face in critical situations. This study, entitled Central Venous to Arterial Carbon Dioxide Difference and the Effect of Venous Hyperoxia, a Limiting Factor or an Additional Marker of Severity in Shock, explores the effects that carbon dioxide difference, as well as high levels of oxygen in the venous system, known as hyperoxia, have on shock severity. In this study, patients within the intensive care unit were observed. This study sought to analyze hyperoxia and further define whether the central venous to arterial carbon dioxide gap and the central venous to arterial carbon dioxide / arterial to venous oxygen difference ratio are helpful in prognostic outcomes in shock management. This illustration depicts the pressures of carbon dioxide and oxygen in the blood and correlates to the actual levels of each gas. In this study, the central venous to arterial carbon dioxide gap is the difference of the pressures of carbon dioxide in the veins to the pressure of carbon dioxide in the arteries. In healthy, normal functioning individuals, the pressure of carbon dioxide in the venous system, represented in blue, should be higher than the pressure of carbon dioxide in the arteries, represented in red. This accounts for the incorporation of carbon dioxide into the circulatory system from the tissues and expulsion of carbon dioxide into the lungs. The normal value for this difference, as shown, is 6 millimeters of mercury by subtracting 40 millimeters of mercury as the pressure of the arteries from 46 millimeters of mercury as the pressure in the veins. When this difference rises above 6 millimeters of mercury, the believed etiology is low cardiac output, although the exact mechanism is unknown. So, this measurement is useful in shock patients to assess their cardiac output decrease and change over time. Furthermore, the ratio of central venous to arterial carbon dioxide pressure difference to arterial venous oxygen content difference is the comparison of the carbon dioxide pressure change versus the oxygen content change between the artery and venous systems. The ratio considers not only carbon dioxide production in relation to cardiac output, but also the efficiency of oxygen consumption. This ratio is believed to be more efficient in assessing patients prognostically than the central venous to arterial carbon dioxide gap alone to detect the body's need to use anaerobic metabolism and therefore lactate clearance. This ratio has yet to be standardized as the exclusive focus of study in shock patients due to a cited limitation. Since oxygen levels affect the binding of carbon dioxide to hemoglobin, as discussed previously as the Haldane effect, in instances of low oxygen levels known as hypoxia and high oxygen levels known as hyperoxia, the ratio is not as reliable. Even with the same carbon dioxide content, hypoxic condition would cause lower oxygen pressure, leading to high carbon dioxide pressure and therefore less carbon dioxide hemoglobin binding. Conversely, for the same carbon dioxide content, hyperoxia would lead to more carbon dioxide hemoglobin binding. The resulting increased or decreased clearance can cause confounding due to the unreliable reading of true carbon dioxide content due to excessive oxygen or excessive oxygen deprivation in the system. Due to the unique specificity of this study, only 20 participants were included in the prospective analysis. The authors depicted their inclusion criteria in the table provided. Most notably, median age was 59, 65% of the subjects were male, 70% were experiencing shock from a sepsis etiology, and all participants were given norepinephrine and under mechanical ventilation. Furthermore, patients were only included if they were experiencing shock and required mechanical ventilation within 24 hours of admission to the intensive care unit. Finally, Patients were excluded from the study if they were under 18 years of age, were pregnant, or their oxygen requirement was greater than or equal to 0.5 at baseline. In graph A, represented by the gray circles, the pressure ratio had a significant correlation with the central venous oxygen pressure, while the respiratory quotient represented by the white circles did not show significant correlation with the central venous oxygen pressure. The same is true for graph B. The gray circles representing the pressure ratio had a significant correlation with central venous oxygen saturation, while the white circles representing the respiratory quotient did not. The lack of significance for the respiratory quotient correlates with the prediction that the difference between carbon dioxide content and pressure in altered oxygen states can lead to confounding of true patient oxygen status. Further results of the study, as shown in both graph A and graph B, illustrate a statistically significant increase in both parameters in response to an oxygen challenge test. The values shown were taken at baseline and immediately following the 5-minute hyperoxygenation trial labeled OCT. This further exemplifies the assumption that the addition of oxygen alone can increase the parameters even if the underlying shock is not being improved. After all, this test was only conducted for 5 minutes, and the increase was significant while shock resolution was not met. In conclusion, this study did find that the central venous to arterial carbon dioxide difference is a factor of consideration in shock patients. However, to say that it is a limiting or definitive prognostic factor is a bit of a stretch. While a rise in this difference may be indicative of cardiac output inefficiency, it can also be drastically altered by hyperoxia. So, careful consideration and looking at the full patient picture is imperative to avoid being confounded by these figures. Furthermore, assessing oxygenation status of hypoxia and hyperoxia helps the evaluator truly understand if the central venous to arterial carbon dioxide difference is significant or confounded.